And and I will tell you a little bit about our story, how we grew up, if you wish, in this environment. And as you see, well, I'm representing here a couple of organizations. And before going now into the platforms, just a couple of comments here. So I'm representing a university, a research center, and a company. And maybe I start with the company. The company is called TRIUM Analysis Online. It has been founded as a startup company of the TRIUM many years ago, almost a quarter of a century. Well, we have the university itself, Technical University of Munich. We have 3 universities in Munich, as you may know. There is the Technical University of Munich, there is the Ludwig-Maximilians University of Munich, also in town, and then there is another university called the University of the Armed Forces. And well, TUM has all these nice departments: physics, informatics, mathematics, medicine. I'm actually located in the electrical engineering and information technology, and some of these departments are competing to somehow embrace this new emerging topic of artificial intelligence and big data. So it's a very nice network of students. Now the research center is a baby actually between the company TRIUM and the university. Also, well, more than 20 years ago, the two together started a multiple sclerosis research center with some international funding that was available at the time, and I will tell you a little bit about what came out of this initiative that's still existing, and there is some relevance to CPG research. Now, if you look into the structures, well, you have a university, research centers, and companies. There is, when I was giving this talk to a pharmaceutical company, they said, well, that's interesting. They've read a book about Accelerate from John Cotter, and he has talked about these kinds of structures, and they call it the dual operating system. So on the right-hand side, we have something that we have here today. It's a bit chaotic, but there is a lot of interest and open agile dialogue and so on, which is good for innovation. But on the other hand, if you are in a company, well, you better have a QM system and a clear documentation of why you've made changes and who has made these changes and who has approved this. It's very important, otherwise there's no chance that you can have a high-risk medical device on the market. And the question is, how can you bring these two lives together, that you can be innovative, on the other hand you can bring the innovation really to the market, and it's absolutely non-trivial. So the way we've been experiencing in the last 20 years is using this dual operating system innovation. Well, if you represent these different entities, well, university for research education, research center, and then a company that of course needs to make profit, you are, and you have many conflicts of interest. I have many conflicts of interest. Private ones, you have to earn your money, you want to be an independent researcher and so on. And therefore, this paper here on the left side, Bias, not conflict of interest, is the enemy. A very nice paper in neurology years ago, where they say, well, if it's not the problem that people have conflicts of interest. The problem if you have a hidden bias. What I promise you, what I'm telling you in the coming 15 minutes or so, I'm trying to be as honest as possible. So in case of doubt, I'm trying to say the truth. But you should know well that I have lots of conflicts of interest. Okay. Well, and I should also say the umbrella over all these activities is actually trying to improve human health. You can do this as a company, you can do it as a research center, as a university, but whether or not with your products and devices and research will actually improve human health is an absolutely non-trivial question, as we've seen also in the talks before. Okay, now let me come to the platforms. So we have 3 platforms I'm going to mention today. It's our fetal monitoring platform, then data warehouses that we have built over the years, And then very briefly, activity monitoring. There is some link to fetal monitoring, but it's somehow an independent field of variables that we are pursuing. Okay, now fetal monitoring, I've broken up now in a couple of topics. Some of them will be independent slots that we have with Antonia when we talk about mobile home monitoring, and also about the big CTG data initiative, so that is going to be discussed separately. But here I'd like to just give you a very brief snapshot of somehow what is it, our current solution, which is called TRIUM CTG Online. So that's just the surface, where you have a web-based platform where you can get CTG monitoring with an automated decision support alarm system according to the structures of FIGO, and I think maybe the number of parallel recordings is something like 64, Christian, if I'm not mistaken. Okay, so then the history. I told you it's going to be a bit longer, but I will not give all the details here. So we actually started back in 1996, well, a long time ago. My background is physics and mathematics, and I was hired by my former boss, Professor Nice, at the Institute for Medical Statistics and Epidemiology, 50 meters this direction. So the building is still there, but at that time this was a very different structure. And he hired me as an anti-statistician, as he called it, in a research project, basic research project about change point detection, with the idea to, well, find improved online algorithms in medicine. Very, very unspecific topic. It was great. And as a physicist and mathematician at that time, I was extremely arrogant. And what I will tell you now is somehow coming out of this initial naivety and arrogance, if you wish. So when I started in 1996, I quickly found that, well, there are some problems in these alarm systems, mainly false alarm systems in ICUs. Then we had a random collaboration with the obstetrics department, and I realized, well, by reading a tiny little bit in the literature, there is one group that is really outstanding. That's the group in Oxford. So I took the phone and I called Professor Dawes and found from the secretary that he had passed away a couple of months before, I think in May 1996, and a couple of months later my phone call did not work there. But we continued to be interested in what's happening in Oxford, so from that point of view it's a big pleasure now to reconvene somehow. Well, we developed then some conceptual work in biosignals based on some basic physiology and physics to find universal tools for detecting drifts, shifts, and outliers and missing data in biosignals. That actually made it into a patent application that was granted, that opened us up some funding from Bavarian Ministry for Economic Affairs and other stuff. And this patent allowed us to develop algorithms that we found to be useful in CTG analysis. And the good thing is that a core part of this algorithm actually was defining and calculating the baseline, which was at that time considered to be a tough, complicated topic. And one of the problems is that the definitions of baseline that are out there in the literature are crazy. They are circular, and I mean, you all know this, I think. And in order to calculate the baseline, you should need to know where are the accelerations, decelerations, but they are defined as deviations from the baseline, and that has been copied in textbooks for decades. It's very strange. Yeah? Okay, so that was the basis. I just picked out this picture because it was so important for us in the future, and then many other algorithms are building on this core part that is calculating the baseline. And as it was developed in an environment where you have real-world problems, namely noise and missing data and outliers and all this, the algorithm was built to be robust in a clinical environment. We've been very lucky early on to have a distribution partner. It's GE Healthcare that you may know, and such that from then on we could concentrate on further developing the technology and the algorithms and collecting data and being involved in guideline developments. But GE Healthcare is doing the sales and the marketing and distribution. Well, after a while we developed a mobile version. We come to this point in the topic, I think on Saturday, Antonia, about home monitoring. And that was back in 2006. We have a Japanese version, and where we have now relaunched last year, triggered by COVID, the home monitoring part. Okay, so the snapshot, call it global presence, of what's happening right now with the support, obviously, of GE Healthcare. So we have something like 500 installations in total. The first one was done in 2001, several languages, several countries. And then we have estimated the number of recordings that has been done with these algorithms, with these systems, like a bit more than 22 million. Although we don't know how many of this led to actual birth, but I mean, there have been many, many millions of pregnancies that have been using this system, which is important, of course, for the risk-benefit ratio. I come to that. Now the future. Well, some of the topics are, of course, also here embedded in the symposium. Well, big CTG data, a topic we're going to be discussing about, because that's already from the talks we've heard so far. In my view, there is a need for high-quality annotated data collection, sharing, doing reasonable analysis plans and independent validation of what's going on, because the problems are such that they cannot be dealt with a couple of thousand data points. It's massive, and it will not happen, in my view, in the context of randomized clinical trials. I think also Cochrane has understood that there are limits. And so therefore, high quality real-world observational data, in my view, will sooner or later replace some of the work that has been done in clinical trials. Well, now our own contribution in this context was years ago. We had the impression, after analyzing now these FIGO guidelines and the mess that is out there with agreeing on what are the normal ranges, we thought, well, let's collect a lot of data and let's just do the analysis. And what we've done is we had 3 different clinics in Germany, and over a time period of 8 years we collected the CTG data without knowing the outcome. The argument was bad outcomes are very infrequent, so we just pool these data and treat them as normal and just look at the histogram, find out what are the normal ranges, try to do a validation in an independent data set and try to find out, do we find this in the validation set? And at that time we could find, well, that Geoffrey Dawes, who said always 110 to 60 is what we also could replicate in the data. And at that time, the normal ranges, as you may know, have been voted down by a group of old, gray-haired men to 110 to 50 without any evidence, and then raised again from 110 to 60, at least in Germany, also in my view without any strong evidence that this is a good thing. And so we had then published a paper where we said, well, the normal ranges in a reasonable definition are 120 to 60, and if you really have this new broader range, one should have accompanying research to really demonstrate that this is improving the situation. So it's just one example of what we think is big data CTG research. You need, of course, algorithms to go through this. In this case, it was a bit more than 1 billion individual heartbeats where we could somehow get this result. Now, machine learning AI, well, as I said before, is very important to many of us, and we need to talk about how to share data and how to combine data to do this kind of analysis. Well, we have research and tools in this direction of improved audiovisual improvements for the people actually working in the clinic, and our philosophy is to be device agnostic. We are at the core a software company, and so we'd like to be able to communicate with whatever high quality devices are out there, both in the clinic, but also now for the new, hopefully new emerging field of home monitoring, where the core system can be linked to all kinds of devices. Well, I've given one example. This is the Japanese version, and as you may know, they have a 5-tier system. And also here, I would really encourage to find future research demonstrating that the superiority of either a 3-tier system or a 5-tier system based on hard data. I just cannot believe that Japanese babies are so different from other babies. And that somehow should be the driving force. Okay. Well, I'm going to touch this. Well, we will talk about what we call the mobile fleet on Saturday. I just want to mention that this is somehow our impression for the future, triggered to a certain extent by the pandemic, that home monitoring probably will take off. And I would hope to see here also some momentum to support this. And I know some companies are here that are also moving this direction. There's fantastic development in Denmark. So, okay. All right. So then I would then stop at that stage with my talk, and let me respond to any questions. Go ahead, Julian.
Hey, Julian, nice talk, thank you. I have a quick question on the last point here. You mentioned the mobile fleet, and of course the impact the pandemic has had on adoption of remote technologies. Which conditions, which risk factors do you think will lead the charge in the adoption of remote technologies? So is there a patient population that you think will be the first one to benefit from that?
Yes, it's an extremely good question. Thank you. So our initial view was, well, being a company, well, then you are always afraid of risks and so on. You try to control this. So we felt that in this new relaunch, we should be on the safe side and say, well, it's only for non-risk pregnancies. And well, the feedback from the obstetricians was, are you crazy? We don't have any low-risk pregnancies here in Germany, a tiny fraction. So you would exclude most of the people from this. And currently, there is now a growing number of risk factors that are taken to be very meaningful inclusion criteria for the introduction. And well, we can talk in detail about this, but that is the overall direction. And in particular, in the times of pandemic, it became bloody obvious that it is unethical not to offer these technologies, because the risk that you get infection all the way to the hospital, in the hospital, and so on and so forth, the disease course for COVID-19, at least in the early stages, was much more severe than the normal disease course. We knew people from Israel who had talked about the problem to use telemedicine in the clinic because the pregnant women had to be moved out of the obstetrics department in special units where they did not have any monitoring solutions, so they used telemonitoring devices to be able to handle these severe cases. So and that's I think for an evaluation of the risk-benefit ratio really important. So in my view, the future is going to be for risk pregnancies, well-defined risk pregnancies. In Denmark, where we come to that point, I mean, a brilliant paper from Olaf Pedersen and colleagues from experience in Aarhus and Copenhagen, they have done this in more than 400 pregnancies, not high risk, but even highest risk. And they could find solid information that the risk is actually either the same or even they have a lower risk as compared to treatment in the clinic.
Are there any other questions?
Yes. So I'm talking about business and not about clinics or science. Do you think that the future of such kind of monitors will be towards the consumer electronics instead of medical devices? because I think it's much more useful for a pregnant woman to know that the heart of the fetus is beating and so on. So it's like you know, smart watches that catch your heart rate without any scientific final scope, because it's only to be sure that you have a regular beat, something like that. I think that the future in terms of business of such kind of devices will be towards the consumer electronics and not towards the medical devices. That's
Okay.
my. I want to.
Yeah, that's true. Yeah. So now I'm back into my initial comments. Well, that I'm trying to give an unbiased answer. So I'm in this field as a researcher, as an academic, but also where we have all kinds of projects and products. So I take this example from wearables in general. Yeah? There was a recent overview article in The Economist, extremely well done. Yeah? And they also asked exactly this question: is the future of wearables now going to be high-end medical grade, or is it consumer grade? And they say, well, it's going to be, there will be the two ways, but for real useful medical applications, it will be medical grade, or that was their view. My view is in clinic use is a high-risk medical device. Class 2B European regulations, there's no question about this. If you want to do this outside, the risks will not be negligible, and so you will still have a Class 2B medical device. So in my view, the professional way to expand this is a careful way to now roll this out as a medical device. And I'm skeptical also when we talked in Oxford, there was one remark, well, that there is a risk. Well, if people are using these devices without professional algorithms or professional support, well, the number of false positives and unnecessary interventions will further go up. And this mistake that has been done when CTG was introduced many years ago should not be done again. So my personal prediction is, or hope would be, it needs to be in a professional medical device regulated area.
The future will show. One more question from Perigin, Mr. Philip.
Thank you for your talk. Please let me know if I missed a nuance in your discussion there. But if I understand correctly, you in fetal monitoring or fetal CTG analysis, you seem to be making the point that it's enough to characterize the normal babies, because most babies are normal. Just pool all available data and call that normal. Are you saying that it's not so important to characterize the sicker babies and the very pathological babies?
Well, maybe I was too brief there. You're completely right. No, I mean, I was picking up this normal fetal heart rate topic as an example what future studies in big data should do. Yeah? And I've also been really encouraged because there was a recent paper highlighting the importance of what they call the baseline study, by saying this is the kind of stuff that needs to be done with big data. We have to have a validated package of algorithms, and then you should have a validated and approved analysis plan, and you should do step-by-step check of your assumptions and try to make predictions and so on. And if you do not know what is normal, that's a very general insight, then you cannot know what is abnormal. So from that point of view, the most basic thing in computerized fetal monitoring, in my view, is what is the normal fetal heart rate?
Can I add something? I think it was more also in the context of clinical guidelines as well. So even if you were talking about physicians, the clinical guideline that says baseline above 160, we know it's very controversial, 150. So we also, when we analyze thousands with algorithms, we are able to start putting that data that actually the onset of labor 150 is already too high. Later in labor it's 160. So I think it's not even about prediction or computerized algorithms, it's about using the power to analyze large archives with computers which humans can't, and just pull that frequency data. Am I correct in
Yes,
Even as a
that's true.
basis.
But there are, of course, further steps that need to be done. For example, can you link the FIGO colors? Yeah, because that's what's going on. Well, that you have a continuous assessment every couple of seconds. You do a check of 30 minutes or so of a CTG trace, and you check is it FIGO green, red, or yellow. And then, of course, the interesting thing is what's the relationship to a gold standard. And then the question is, what is a gold standard? Should it be UPGAR? Should it be pH value? Should it be depth? With all the complexities we've heard about. And well, what we see and what others see is that you find some relationship between FIGO red and some indications of a bad fetal outcome, but this is not impressive. I have not seen anything really impressive where you would say, well, it's like a pacemaker. It's just no doubt, it's obvious this is curing or this is saving lives. And that's, I think, a big problem in the field, that if I go back to one of the other talks about Cochrane, if you take Cochrane seriously and say, well, this is the best evidence we have, go to Cochrane. I think it was in your talk you said, well, there is no evidence for improvement and some evidence that we are over-treating, increasing the C-section rate by 20% or something. If you take this seriously, you would say, well, unnecessary C-sections, well, this is a surgery, they carry risks, heavy risks for the mother and for the baby. So if you take Cochrane seriously, you would say, well, with this technology, we're continuously killing mothers and babies. Yeah? If you're outside of the field, then that's...
Yeah, and in the UK, there is quite strong calls as well by certain bodies to be able to abandon CTG, and I can understand where they're coming from.
Yeah, and the only thing is, I mean, is in some of the newer Cochrane reviews, they say, well, things look different when you take into account electronic fetal monitoring. But these statements are not backed up by really high quality studies so far. And in my view, that should happen, because you cannot stop the usage and say, let's reintroduce it in a proper way.
Those are excellent points that give us a lot to think as we go through the meeting, and I hope we're going to have a chance to talk about it offline as well. So looking forward to the next talk. I want to thank you, Martin, for that exciting overview of the development and new things to come.